The video today is about GI bleeds and then blood transfusion and what we need to do, and then we'll go into anaphylaxis and what we do for that. All right, so let's talk about GI bleeds. So with an upper GI bleed, so we're talking about in the stomach, the duodenum or the esophagus, that's kind of considered to be upper GI bleed. So 60% of bleeding usually occurs from the same place as the patient had it before. So it's a really good idea to ask, hey, have you had a history of this before? How long have you been having this kind of pain? How long have you been having these symptoms? Have you had this happen before? What did they do about it? So yeah, and then we're going to ask about all the risk factors. So risk factors are if they had a AAA, so an abdominal aortic aneurysm, and then had maybe had it surgically corrected or had some sort of graft, then they can bleed from that site. If they've had a gastric anastomosis, so if they've had part of their stomach removed and then pieces, put together with the removal being taken out, then they can bleed from that site. Okay. And then our liver disease folks, those guys can bleed pretty good upper GI bleed, and then alcohol abuse, because both of them cause liver disease or can cause liver disease. Alcohol abuse can cause ulcers as well, but esophageal varices are those big giant fire hoses or varicose veins inside the esophagus. And when you're looking down with a scope, when I worked in endoscopy and we were looking down with the scope down that esophagus, it's all these little blue cords that are protruding into the lumen of the esophagus. And those are all the varicose veins. Well, those varicose veins get ruptured and then they bleed like stink and they don't stop. And so when you get down there with the scope with an active variceal bleed, there is just blood coming everywhere and you can't figure out where it's coming from. Those have to be banded with an endoscopy procedure to fix them. So, but that's caused by liver disease usually. All right, and then H. pylori is the bacteria, right, that causes ulcers. So, and then our peptic ulcer disease and our GERD population. So all of those are kind of ulcer related. And then chronic non-steroidal anti-inflammatory drug use, that can lead to ulcers, right, because it breaks down the protective layer lining of the stomach. And then our anticoagulate meds can put us at risk for more bleeding if we already are, dealing with ulcers or other things on this risk factor list. Smoking can put you at risk for having ulcers. And then our bleeding disorder people, so people who don't clot, okay, a GI bleed. All right. Okay, let's talk about those for just a second. So now, a lot of times they'll have hematemesis, so they'll be vomiting blood, okay? And it could be a couple things. It could look like frank blood, which is otherwise known as bright red blood. And that means that it's ongoing or that it's a current bleed, that it's bleeding right now. If it's coffee ground emesis, then that means that the bleeding is limited, or it might be old blood. They might be bleeding from somewhere actively, but it's very limited, okay? Nevertheless, both are a little alarming. Obviously, the bright red blood is much more alarming than the coffee ground emesis, okay? All right, and then melena is in the stool. So melena has to do with black tarry stools. That's the technical term for that. And that usually means that you have an upper GI bleed somewhere because as it takes longer to get down to the end of your colon where you then poop it out, if it's black, then it's a little bit older blood, okay? And then hematocezia is red or maroon blood that's in the stool itself, okay? And that usually means you have a lower GI bleed, but it can also mean that you have a massive upper GI bleed, and you're bleeding so fast that your body doesn't even have time to clot or digest the blood, and it's so much that it just comes out the way that it started. So it can mean a massive upper GI bleed, or it can also mean that you have a lower GI bleed, more commonly. All right, now let's get into some assessment findings that you find that we'll discover on these people. So they usually have upper abdomen tenderness, pain, or otherwise known as epigastric pain. So epi meaning on, or kind of around that area, and that's kind of right below the xiphoid. So that's considered epigastric, if you push right below the xiphoid and they have tenderness. They'll have signs and symptoms of hypovolemia, and these are some of the rules of thumb that we'll deal with. So if you have resting tachycardia, then you know that kind of a general rule of thumb is that they've lost up to 15% of their total blood volume. If they have resting tachycardia, so that means they're just sitting there, they're not doing anything, and they're tachycardic. If their systolic blood pressure goes down 20 points and or their heart rate goes up 20 points from recumbent to a standing position, otherwise known as orthostatic vital signs. So orthostatic vital signs, we will take a lot of times in the ER because we're trying to determine, are they orthostatic or are they hypovolemic? So if they, so we first start with a blood pressure and a heart rate, laying down flat. Then we sit them up, and you just have them sit at the side of the bed, and you take the blood pressure and heart rate again. But you wait about 3 minutes because initially your blood pressure and heart rate will spike when you go to sit up. So you want to wait for it to kind of stabilize a little bit, so you give it a couple minutes in between each position change. Then you take your heart rate, blood pressure sitting. Then you do the same thing standing, so you kind of stand by the patient so they don't pass out. And then you also record, are they symptomatic? Are they having dizziness? Do they feel like they're going to pass out? If they do, obviously sit them down and don't finish the test. And then, so they're considered orthostatic if they have a drop in blood pressure of 20 points systolic or an increase, and probably at the same time, of heart rate 20 points above their baseline. Okay, from recumbent to a standing position. And that's known as orthostatic vital signs. So that's what we're looking for there. With supine hypotension, if someone is lying completely flat, right, supine, and they're still hypotensive, you know that they've lost about 40% of their total blood volume. So supine hypotension is very ominous. That's not great, okay? Other interventions that we can do, things that we can do for our hypotensive or our hypovolemia, if we know that we have active bleeding. All right, so you want 2 large bore IVs, so that's really important, and we already know what large bore IVs are, right? So preferably that would be an 18 gauge, but, and that will help with faster administration of those blood products and fluids. But if you can't get an 18, the minimum IV gauge for giving blood is a 20 gauge. That's acceptable in an adult. So what happens to our red blood cells if we are less than a 20 gauge? So if we go 22, well, the cells are going to lyse, okay? So that is actually why you have to have a 20 gauge in order to give blood. All right, so we do a lot of fluid resuscitation with isotonic fluids, okay? And then the transfusion decision is usually based on if they're actively bleeding. So if they're actively bleeding, you don't really pay attention to what their lab results are. If they're actively bleeding and their vital signs are showing that they're orthostatic, right, then we don't wait for lab results to transfuse, unless, you know, obviously you're going to wait for your type and screen and all that. But if their hemoglobin is less than 8, then we transfuse. So you either do one or both, okay? So they either base it off of active bleeding and the hemoglobin's already low, or they have active bleeding and the hemoglobin's okay, but they don't want to wait that long to treat them until their hemoglobin drops, because it's a bit of a delayed response. So then they'll just proactively give them blood, okay? All right, so prior to transfusion, we have to do a bunch of things, okay? So we need to make sure we get a type and screen cross match, right? And we have to get consent. And whoever's doing the blood, so whoever's giving the blood can get consent from the patient, right? So if you're the one doing it, then you get consent from the patient. So whatever RN, has to be an RN, and you can get consent from the patient or from the patient's family if they're unable to give consent. If there's no one there, then it's considered implied consent, and you have to have 2 nurses witness and sign. All right. So we make sure that the patient has 2 large bore IVs. Hopefully we got some 18 gauges. If not, 20 gauges work. We're going to obtain our blood tubing. Remember that the blood tubing has a really big drip chamber, and it also has a filter in it that's kind of maroon colored. And we'll talk about that in a second. We're going to prime the tubing with a 500 ml bag of NS. So we don't use the whole 500, but we hook the 500 to the fluid side of the tubing. And then we close the clamps off to the blood before we prime with the saline, okay? And I'll show you how we do this in a second. We're going to obtain blood from the blood bank. So this is after we've got consent, we've primed the tubing, we're all ready. We get the blood from the blood bank and we inspect the blood with our eyeballs, make sure it's not clumpy, make sure there's nothing weird in it, okay? You're gonna check the expiration date on the blood bag and also check that the blood type matches the patient's blood band, okay? So the blood type on the bag has to match the patient's blood band and has to match the order in the computer. Then we check our 2 patient identifiers. So you ask your patient the name and date of birth, check their wristband, make sure it's the right patient. Then we check the patient blood band number. So the patient on their blood band, so they'll have a wristband with their name on it. And then they'll also have an extra band that will be their blood band. We have to verify that number is the same as the number on the blood bag, okay? So that number on the patient's blood band has to match the number on the blood bag, has to match the number that's in the computer. Then the unit number that's on the blood bag, that is talking about the unit of blood, it also has a number. And we have to compare that with the order, either the slip if you're doing an emergent transfusion, or with the computer with the blood bank, okay? All right, then we followed our facility protocols. So some facilities still have you do a double nurse check. And a lot of facilities now, because of electronic charting and how you can scan all of these barcodes, it obliterates the need for 2 nurses, okay? Because you're verifying with the computer, and the computer won't let you start the blood unless you scan all of the barcodes in the right order. So it just depends on your facility, but whatever your facility has you do, whether it's 2 RNs or whether it's the electronic blood verification in the computer, okay? Then we check our pre-transfusion vital signs. So we have to get a set of vitals before we start transfusing. And that we have to chart and record that, that's required. And that's our blood pressure, heart rate, respiration, sats, temp, okay? Then we close the roller clamp, so RC stands for roller clamp. We close the roller clamp to the NS. We open the roller clamp to the blood. Then we set our rate on the pump to the blood. We set our rate for no more than 2 mils per minute or 120 mLs per hour. You can't do more than that for the first 15 minutes. Then, so now we hit start on the pump. Then at 15 minutes into the transfusion, we get another set of vital signs, okay? Then if everything's okay and the patient's not having any sort of reaction and their vital signs are fine, you don't have an elevation in temp or respirations or anything like that, then we can increase the drip rate per hospital policy, and it's most likely dependent on the unit. So in the ER, depending on the emergent status of the patient, we might be putting these people on a rapid infuser and infusing these units in over like a minute, okay? It might be very, very quick. If they're on the pump and they're somewhat stable, but they are very orthostatic and their vital signs are trending towards that really bad hypovolemic shock, then we might turn it up to 500 mLs an hour so that we can get it in them over a half hour, okay? So the most regulations for most hospitals, you have to give that blood. You cannot drip it in more than 3 to 4 hours, I believe. And so you really need to make sure that you stick to that 125, and that, or some places you can go up to 150. Some places after that 15 minutes you can go to 200. It just depends on the unit policies for blood transfusion. Now, excuse my drawing. We're going to go over this really quickly. So for your blood tubing, it comes in a Y, and then it all threads down to the filter, and then that goes above the pump. So you actually have 3 roller clamps in your blood tubing. So you have the roller clamp that goes down close to the patient. Then you have the roller clamp that goes to each of the bags. So when I said we were priming with our NS, we get our tubing, then we prime, we close off this roller clamp, okay, to the blood bag, and we prime, we spike this side, okay, so you have 2 little prongs, and one goes to the blood and one goes to the NS. So you spike this NS bag first, we're going to prime it, okay, with our NS, and 4 policies might have you do this a little differently, but as a general rule, this will work. Now, and this is closing off this roller clamp and keeping this one open, all the way down to the end of the tubing. Now what will happen if you forget to close this roller clamp off is it will prime all the way up into the bag, and it won't go down to prime the tubing. So it'll prime up into the blood bag and actually increase the volume of the blood and start mixing the NS in the blood. So we don't want to do that. So close that guy off, and then you're going to open this one, while you prime your NS, all the way down to the patient, okay? Now, once you have all your checks done, you've done your initial set of vital signs, you've got all your scanning done, you're ready to rock and roll in your charting, then we're gonna open. So we put our little drip infusion set into the pump. The filter goes above the pump, okay? And it kind of has a little fenestrated thing that kind of filters out all the stuff we don't want, okay? Any clumps, if they may be, or anything like that, so that doesn't go into the tubing. All right, so then we open the roller clamp to the blood bag, and we keep this one open to the patient, and then you start your drip rate. So you're gonna start it at a max of 120 mLs per hour, okay? So in the ER, I feel fairly comfortable starting at 120 mLs per hour at doing the max, but I would just go by your floor policies if you work on the floor or in the ICU, okay? So that's kind of how that works on the pump, how the blood tubing works. So when we talk about priming it, we're gonna close this one, keep this one open. Then when we start the blood, we have to close this one, because if we don't, the blood will go right up into the NS bag. That's not gonna work, because it's not gonna get to the patient. So you're gonna have to open this one, close this one, and then get down to your patient. Obviously this roller clamp is open as well. All right, okay, really quickly, I'm just gonna go over a few little factoids that we might need to know. So iron pills and Pepto will turn your stool black, okay, FYI. So sometimes it's a good idea to ask these patients, hey, have you been taking any Pepto or iron in the last little while, last 24 hours? Because that's kind of an interesting thing to maybe find out, rule out, because it will turn their stool black. All right, and then just a note that it takes 4 to 6 hours for the H&H to increase or reflect post-blood transfusion. So you give a transfusion and then you want to wait and not get their H&H or their current CBC until about 4 to 6 hours after that transfusion. Then you'll start to see the difference in their H&H. Each unit of blood, as a rule of thumb, will increase the hemoglobin 1 gram per deciliter, or 1 point, okay? So every unit of blood will increase their hemoglobin another point. And remember that we base transfusion off of hemoglobin and not hematocrit, because hematocrit doesn't necessarily tell us how many red blood cells that we've got in our blood. It will deceive us, because if we're hemodiluted, right, we don't really know what our true hemoglobin count is. So they base transfusion off of just the hemoglobin. Okay, now initial H&H may be within normal limits. So let's say your patient comes in and they're vomiting bright red blood, and you go to check their H&H, and it's probably going to be initially fine if the bleeding just started. So it may not lower that H&H until up to 24 hours after the bleeding has onset. Now, obviously, it's going to lower it a lot quicker if the bleeding is worse, or if you have a massive bleed, it's going to lower it a lot quicker. But it may take up to 24 hours to show a difference on their H&H. So those are just kind of good things to know. Okay, now we're going to talk about our blood transfusion types. Blood transfusion reaction types. So there's 5 different types of blood transfusion reactions that you can have. All right, so we can have a mild allergy, and that's rash, itching, kind of an urticarial appearance, generalized itching and redness, and there is no airway involvement. So this is just a mild allergy, and why is it mild? Well, there's no airway involvement, okay? That's how you know it's mild. So what do you do for that? Well, we stop the infusion, you call the provider, and they'll probably order some benadryl or solumedrol, okay? All right, cool. So now with a febrile reaction to blood, febrile type transfusion reaction, is you have an increase in temperature above the patient's baseline. So that is, remember we took their vitals right before we hit start on the pump? You're going to go off of that temperature. So let's pretend that we got a temperature of 37.5 before we started the blood, centigrade, and then now they're 38.5. So now they meet requirements to qualify for that febrile transfusion reaction. So if they go up 1 degree Celsius, or if your hospital is measuring in Fahrenheit, they go up 1.8 degrees Fahrenheit, then they can be considered a febrile reaction. So same thing, you stop the infusion, you call your provider, you get some Tylenol on board, IV, PO, per rectal, however they want to do it. All right, now, this is when we get a little bit more serious. So hemolytic reaction is when you have the incorrect blood type, okay? I've never had this happen to me, just because of, well, you know, two nurse verification, electronic charting. It's almost impossible for this to happen, but it still does, and so we need to be made aware of it. All right, so they'll have back pain, chills, they'll have increased temp, they'll have lower blood pressure, some pretty good hypotension, and they'll also have blood in their urine, so hematuria, okay? Hematuria, there we go. I spelled it right now. Okay, now we have to stop the infusion, call the provider, and then we give all the crap to the blood bank. So you take the entire infusion out, including your blood tubing, your blood bag, the whole thing, and you give that straight to the blood bank. They have to test it and do all their stuff. Okay, now fluid overload is another transfusion reaction, and these are the same exact signs and symptoms as heart failure. Okay, so we're going to stop the infusion, call the provider. They'll probably order Lasix. Okay, all right. Now anaphylaxis. This is the one that we're going to focus a lot of our time on, because this can happen randomly when you weren't expecting it. Even if you've cross-matched, you've got all the right blood type, you've done everything correct, you can still have anaphylaxis to blood. All right, so they'll get angioedema, and that, for those of you who don't know what angioedema is, that's clown lips, right? So their lips get so big that they spread almost across their face like a clown. Their tongue gets so big, it protrudes out of their mouth, and they can't keep the tongue inside their mouth. They literally can't close their mouth because their tongue is so big. When this starts happening, this is like when you should be very, very, very concerned, because they're about to lose their airway. Okay? So their tongue gets huge, they'll get a hive rash, their chest will feel tight, so by virtue of the fact that you have clown lips and they can't put their tongue in their mouth, you know you have major airway involvement. Okay? And they'll get dyspnea, they'll have Strideris breathing, and stridor means that you have an obstruction in your upper airway. Upper airway specifically meaning your trachea. So that means that there's an obstruction somewhere in there. And that obstruction is the allergic reaction. It's closing it off because of the edema, all the fluid rushing to the area, and the vasodilation. Okay, and then they'll also have a lot of wheezing as well. All right, so that is anaphylaxis as far as signs and symptoms. So when that happens, we're going to stop, call the provider, and then we give a whole bunch of stuff. And we're going to talk about that in just a second. Anaphylaxis treatment in the ER. And this is the same with any type of anaphylaxis, okay? But in relation to blood, we are going to stop the offending infusion. So whether it's blood, antibiotics, whatever it is, disconnect it from the patient's IV. So I've seen a lot of students and medical professionals think, oh, okay, well, I just need to stop it. So I just hit stop on the pump and turn the pump off, but the blood's still there and it's still hooked to the patient or whatever it is, which means that they still might be getting a little bit of it. So you need to actually disconnect it from the patient, okay? So disconnect it from their piggy tail or their actual IV. Pull it off. Take it away from the patient. Take it off the pump, because if someone comes along and says, oh, what's this here for? Let me start it again. I don't know. So take the whole thing, out of sight, out of mind, stick it over in the sink, all right? Now, we need to call the provider, obviously, which we already would have done. Vital sign check, and if they have NS going in their other arm, let's open it wide up, okay? Now we need to do airway support, so slap some oxygen on them, but I don't mean 2 liters, because that's not going to do anything for them, all right? That's basically, it's not going to do shit for this patient, okay? So remember, their airway's closing off. These are the people that can't keep their tongue in their mouth. So you have a very serious situation happening. So we need to put them on a nonrebreather at 15 liters. Jack it up, go big or go home. If they're not breathing adequately, so if the respiration rate's falling down, their oxygen sats are falling and you can't keep it up, then you're going to have to bag them with an ambu-bag until you can get all the stuff, the drugs that we need to fix the problem. All right, so we're going to give epinephrine, and that's the 1 to 1,000 concentration. In that 1 to 1,000 concentration, if that's the one you're using, you're going to give IM stat max of 0.5, so 0.5 milligrams IM of epi. Wait a second, why, okay, hold on. So why are we giving this? Well, we give it because once you have anaphylaxis, you have what's called a massive release of histamine. So your mast cells come out and they don't like the offending agent, so then they start releasing histamine, and histamine is a potent vasodilator. So then it vasodilates everything. Well, what happens if you vasodilate? Well, then you get a bunch of fluid rushing in, and that happens in the airway too, which closes your airway off. So if we want to get rid of the vasodilation, we need to give a vasoconstrictor, which is epinephrine. So we give a potent vasoconstrictor, IM. But why do we give it IV? Why don't we give it IV? That's weird. We have an IV. Why not give it IV? Well, if you remember from Megacode week, when we give IV epi, we have to keep giving it every 3 to 5 minutes because it wears off. So 3 to 5 minutes IV, and then you have to keep giving it. And nobody wants to have to do that. Plus, we don't want to have to deal with cardiovascular risks. So we give them IM so it lasts longer, right? Okay. So we give them that. So now we are fixing the vasodilation to vasoconstriction with the epinephrine. We give them Benadryl IV. Why do we do that? Why not just the epi? Well, because we want to get rid of histamine. We still want to get rid of it. And so we give that 25 to 50 milligrams of Benadryl IV stat. So now we don't want histamine, so we're stopping the release of histamine right now. And histamine, remember, is the one causing the vasodilation and all the airway swelling. So now we've done that. So we stopped histamine, now we've vasoconstricted. Okay, now we want to give a corticosteroid to prevent rebound anaphylaxis. Because remember that epinephrine and the Benadryl may not last as long as we want it to. That epinephrine may only last for 10, 15, maybe even 5 minutes. Okay, depending on how bad that anaphylaxis is. So we give the solumedrol, which is a corticosteroid, or methylprednisolone. We give that IV a max dose of 125 milligrams. That takes about 4 to 6 to 8 to 12 hours to start taking effect. And so, but it's going to be our buddy, because once the Benadryl wears off, then this will kick in and it will hopefully prevent our rebound anaphylaxis. Okay? So, and then we also give famotidine in the ER, and that's pepcid, same thing as pepcid, and that's given IV, okay? Well, we give a max dose of 20 milligrams, but pepcid, if you remember, pepcid is an H2 blocker. So it also blocks histamine, but it blocks the release of histamine at the stomach. So this is another helper to help block histamine along with Benadryl, okay? Now we're going to watch for rebound. These people, you're on high alert, and you're a 1-to-1 with that patient until they haven't rebounded in about a half hour to an hour. I'd stay with them for about an hour to make sure they're not rebounding. So they could rebound as close as 5 minutes after you give them meds, 30 minutes, 45 minutes, but if they usually won't rebound an hour later. Usually not, but we still want to keep an eye on them. All right, so we may need to redose their epi or their Benadryl. I had a kid one time in the ER who had a severe peanut allergy, and because he was exposed to a large dose of peanut butter, he actually consumed a peanut butter cookie. And so he ate the peanut butter cookie given to him by his babysitter. Anyway, so the babysitter gave him a peanut butter cookie, and then he came to us and he was doing the tripoding and the drooling and everything, and the tongue swelling and the mouth swelling. And we gave him the meds and he got better. Yay, awesome. And then literally 5 minutes from the time I gave him the epi and the Benadryl, he started to tripod again and drool and tongue swell and everything, so we dosed him again. We actually dosed him with Benadryl and epi 3 times. And then the provider said if we have to dose him, or if he rebounds again, we're just going to have to intubate him. So, and they may not get that far. They might just intubate after the second episode of rebounding. So if they keep repeating, if they keep having a repeating rebound of that anaphylaxis, then we're just going to intubate until the corticosteroid kicks in. So they'll probably keep them intubated long enough for that corticosteroid to knock all the inflammation down. Okay, and that's the end of the video.